Welcome, colleagues. Today we review the empiric management of sepsis and septic shock through the lens of the identify, strike, and refine pathway. In an era of escalating antimicrobial resistance, our goal is to balance the golden hour mandate for survival with the long-term necessity of antimicrobial stewardship. Sepsis remains the third leading cause of death in the United States, with 1 in 3 hospital deaths involving the condition. Globally, the burden is even more pronounced in low to middle-income countries, LMICs, where healthcare-associated infection, HAI, prevalence ranges from 5.7% to 19.1%. For patients admitted to the ICU, the frequency of device-associated infections, DAIs, is several-fold higher than in high-income countries, directly impacting our empiric selection. We have transitioned from the SIRS model to the Sepsis 3 definition, life-threatening organ dysfunction caused by a dysregulated host response to infection. This pathophysiology involves a complex cascade where an infectious insult triggers extreme immune amplification. The resulting microvascular thrombosis and leakage lead to the clinical organ failure we must manage. For rapid bedside screening, we utilize the qSOFA bedside radar, identifying patients at high risk of poor outcomes if they meet 2 of 3 criteria: altered mental status, GCS less than 15, tachypnea equals 22 breaths per minute, and hypotension, SBP less than 100 millimeters of Hg. However, formal sepsis 3 diagnosis requires an acute change of 0 points in the SOFA score, which assesses 6 organ systems: respiratory, PaO2, FiO2, coagulation, platelets, hepatic, bilirubin, cardiovascular, MAP vasopressors, CNS, GCS, and renal, creatinine oliguria. Septic shock represents a profound circulatory, cellular, and metabolic crisis. It is clinically confirmed when, despite adequate fluid resuscitation, the patient requires vasopressors to maintain a MAP more than 65 millimeters of Hg and exhibits a serum lactate level equals 2 millimole. The mortality rate for these patients is substantially higher than for sepsis alone. Recognition triggers the Hour 1 bundle, which must be initiated immediately, often before ICU transfer. The core steps include measuring and remeasuring lactate if the initial level is greater than 2 millimoles per liter, obtaining blood cultures prior to antibiotic administration, administering broad-spectrum empiric antibiotics, rapid administration of 30 milliliters per kilogram crystalloid for hypotension or lactate greater than or equal to 4 millimoles per liter, applying vasopressors if the patient remains hypotensive during or after fluids. For ventilator-associated pneumonia, VAP, empiric therapy must target Pseudomonas, MDR-GNB, and potentially MRSA. Regimens typically include a BL-BLI, such as piperacillin tazobactam, or a 4th-generation cephalosporin or carbapenem. If the local MRSA prevalence is greater than 10 to 20%, vancomycin or linezolid should be added. While a 7-day course is standard, Sastry recommends extending treatment to 14 days for immunodeficient patients or those with necrotizing pneumonia. Diagnosis of catheter-related bloodstream infection is ideally confirmed via differential time to positivity, where a central line culture flags positive at least 2 hours earlier than a peripheral sample. Empiric therapy should cover gram-positive organisms with vancomycin and gram-negatives with cefepime or carbapenems. Note that linezolid is not recommended for empiric therapy in CRBSI. Intra-abdominal sepsis. Target GNB and anaerobes using a carbapenem, e.g. meropenem, for severe cases, or a cephalosporin, fluoroquinolone combined with metronidazole. CAUTI. In the Indian clinical context, recommended empiric agents include ciprofloxacin, ceftazidime, cefepime, or piperacillin tazobactam based on local antibiograms. Treatment for severe illness typically ranges from 5 to 14 days. The strike phase is broad, but the pivot at 48 to 72 hours is essential for refinement. Once culture results return, we must de-escalate to pathogen-directed therapy. This prevents further antimicrobial resistance and minimizes collateral damage to the patient's microbiome, while ensuring targeted eradication of the causative agent.